Welcome to our monthly webinar series hosted by the Office of Integrated Healthcare Research and Policy in the Department of Family Medicine at the University of Colorado School of Medicine. Let me begin by telling you a bit about our sponsors and partners. This webinar series is sponsored by the California Mental Health Services Authority Integrated Behavioral Health Project. CalMESA is an organization of county governments working to improve mental health outcomes for individuals, families, and communities. Prevention and early intervention programs implemented by CalMESA are funded through counties through voter-approved Proposition 63, the Mental Health Services Act. Prop 63 provides the funding and framework needed to expand mental health services to previously underserved populations in all of California's diverse communities. The Agency for Healthcare Research and Quality Academy for Integrating Behavioral Health and Primary Care functions as a coordinating center and national resource for people committed to delivering comprehensive integrated healthcare. The Academy focuses particularly on integrating behavioral health into primary care practices and promotes a collaborative environment that fosters dialogue among leaders and other stakeholders in integrated behavioral health and primary care. Key Academy tasks include the NIAC, the National Integration Academy Council, an expert panel of nationally recognized leaders in integrated care, the Academy web portal, and literature repository, where there are over 1,900 citations, the recently developed lexicon for behavioral health and primary care integration, and much more. You can visit the Academy at www.integrationacademy.ahrq.gov for additional information. The Collaborative Family Healthcare Association is a nonprofit, member-driven collaborative organization in existence since 1995. CFHA promotes a comprehensive and cost-effective model of healthcare delivery that integrates mind and body, individuals and families, patients, providers, and communities. Advancing Care Together, a project at UC Denver Department of Family Medicine, is a 4-year program aimed to discover practical models to integrate mental health, substance use, and primary care services. The program is funded through the Colorado Health Foundation and has funded 11 demonstrations, projects that have been organized as a set of diverse comparative case studies and will be linked to support cross-project learning. Before introducing Dr. Roger Kathol today, I'll go over a few housekeeping items for GoToWebinar. On this next slide, you'll see how you can access the GoToWebinar control panel, which will be on the right-hand side of your screen. And here you can control your audio, raise your hand if you have a question, or enter your questions through the chat feature. At the end of this webinar, we'll have a Q&A session where, as you enter your questions, I'll read them to Dr. Kathol and he'll provide an answer. Additionally, the webinar will be posted afterwards on our YouTube channel, which is www.youtube, CUDFM policy channel. Today, we are pleased to bring you Dr. Roger Kathol. Dr. Kathol is currently an adjunct professor of internal medicine and psychiatry at the University of Minnesota and has published over 160 peer-reviewed articles in 25 book chapters. He is a specialist in the care of patients with health complexity, many of whom have concurrent general medical and mental health substance use disorders. He is a board certified in internal medicine, psychiatry, and medical management with extensive clinical and administrative experience gained during 22 years as a physician, teacher, and researcher at the University of Iowa, several years as a health plan medical director, and 13 years as an international health complexity consultant through his management consulting company, Cartesian Solutions. He specializes in augmenting the care of patients with complicated comorbid medical and behavioral conditions through services and payment integration, and consults to hospitals, clinics, health plans, government programs, and businesses as they develop fiscally solvent integrated approaches to medical and behavioral health care delivery, including integrated care management capabilities. In addition to his consulting work, Dr. Kathol works part-time caring for patients at Hennepin County Medical Center in Minneapolis, Minnesota. Today, Dr. Kathol will provide an overview of alternative payment models being tried to sustain value-added care for medical patients with behavioral health comorbidities and behavioral health patients with medical comorbidities. Welcome, Dr. Kathol.
Thank you very much, Emma. So, are you turning over the screen at this point?
Yep, just 1 second.
Okay.
Okay.
Okay. Momentarily, you should be seeing the screen. Can you see the screen, Emma?
Yes.
Okay. So welcome, everybody. It's a pleasure to have an opportunity to share thoughts about alternative payment models and the integration of behavioral health and primary care. Um, at the beginning, I'd like to say that I do have a conflict of interest in that I own a consulting company that specializes in the integration of medical and mental health services, and therefore have a bias that this is an approach that can bring value to patients moving forward. Um, I will share with you thoughts which we'll be talking about sort of long-term comments about alternative payment models rather than current payment models. So for those of you who are on the webinar and are expecting me to provide you with coding and billing procedures that are going to maximize your ability to provide care, that's not what this webinar is about. This webinar is really about creating a payment environment in our health reform system in which behavioral health providers and patients that have behavioral health problems, both those seen in the behavioral health sector as well as those seen in the medical sector, can better access services to address their healthcare needs. So I'll start out by telling you at the front end what the three basic alternative payment models I'll be talking about are the two alternatives. First, we have the existing payment model, which is an independent reimbursement system for medical and behavioral health services. And regardless of whether that's a carved out or a carved in process, i.e. the behavioral health services are owned by the medical health plan, or whether they are carved out to an independent behavioral health care or behavioral health management organization. In fact, there is a different payment system for reimbursing for medical and mental health services. Currently underway in the payment world, there is a transition attempt in which independent payment is being retained with special reimbursement arrangements being made for behavioral health services in the medical setting and medical services in the behavioral health setting, so-called integration and reverse integration reimbursement procedures. The final alternative payment method, and the one that I will be arguing is one that we should be thinking about transitioning to over the next 2 to 3 years, and it will take that long to get to that, is one in which behavioral health benefits become a part of medical benefits in one payment procedure. And so we will launch into a little bit of background about where we are today and how that affects payment, where our patients are seen, and then move into where we would logically want to go if we want to maximize support for patients that have behavioral health problems. So where patients are today, the vast majority of patients with behavioral health conditions, as this Venn diagram shows, are seen in the med-surg sector. So the large yellow oval is the outpatient physical health sector. The little darker, smaller oval, yellow oval circle is the inpatient physical health sector. And then you have patients with chronic illness that bisect those, and those with health complexity, which is sort of the smaller oval in the middle. behavioral health conditions actually are primarily seen in the medical sector. There's that 20% that fall at the sliver at the bottom between, and that's the behavioral health sector. And that is really the sector in which virtually all of the behavioral health budget goes. There's a perception that that's where seriously mentally ill patients are, and certainly about half of seriously mentally ill patients are seen in the behavioral health sector. However, there are a large number of patients with behavioral health problems that are seen in the medical sector that have serious mental illness, probably over half if you run the numbers. And there are a lot of patients in the behavioral health sector that in fact don't have serious mental illness. They have mental illnesses or substance abuse problems that require treatment, and that's the only place they can access it. So now we're going to get into talking really about the higher level look at how patients are taken care of in our system. And this is a schematic of the components of healthcare in which patients ultimately receive care. So there's the purchasers of care, and in the United States, there's the private purchasers and the public purchasers. Private is largely employers, public is Medicare and Medicaid, although there's also individuals that have to pay for their own insurance, and those are self-pay or the uninsured. They are the ones that then pay the fund distributors, and that's the health plans or the insurance companies. And you can see under the fund distributors, there's the medical fund distributors, and those are the ones that pay for med-surg components of care. And in med-surg components of care, there's radiology, there's dermatology, there's pathology, rehabilitation, pediatrics, obstetrics, medicine and surgery. And then there's another payment sector, and that's the behavioral health payment sector. So it's the only allopathic discipline in which there is a completely separate payment process that is used, and that's the behavioral health small triangle there by the larger triangle that's the medical sector. And that drives payment to providers. And so providers are not just the doctors and psychologists and nurses and other health professionals, but it's also the hospitals, the nursing homes, the rehab centers, and et cetera. And so the fund distributors, the medical fund distributors and behavioral health fund distributors then pay the providers, the medical providers and the behavioral health providers to provide the care to patients. And with this separation of payment, largely there is a medical sector that patients receive care in, and there's a mental health sector. And there's a challenge for patients to have coordinated care because the reimbursement processes create barriers, which I will be going over during the course of this presentation. Now, if you look at fund distributors, the medical fund distributors and the behavioral health fund distributors, what you see is, and this comes from a recent analysis by Steve Mellick at Milliman, who created a report for the APA. And what he was able to do is look at total payment for services in the United States healthcare system. And so that's commercial insurance, Medicare, and Medicaid. And what he was able to document is that about 2% of claims for total health services in the United States is for behavioral health service delivery. Now there's another about 2.5 or so percent of claims that are for behavioral health medications in the commercial and Medicare world. In the Medicaid world, it's 3.4% of total health resources are for service delivery. And then there's another 3.4% that would be for medications for behavioral health services. So what the message here really is that the vast majority, a huge, huge majority of the spend for healthcare services is on the medical side. It's not on the behavioral health side. And you'll recall that a significant number of patients with behavioral health conditions are seen in the medical sector, and yet these 2% of service payment from the behavioral health sector really create a barrier for treatment within the medical sector. So many people feel that so if you're only spending 2% on patients that have behavioral health problems, why would you even worry about it? It's so small a part of the budget that it doesn't seem like you'd need to pay any attention to it. In fact, if you look at the total spend by patients that have behavioral health conditions, the vast majority of which is in the medical sector, you find that this small percentage of patients, that is 14% of the population having behavioral health conditions, spend about 31% of the healthcare dollar. So there is a huge amount of spend for this smaller percentage of patients that we're really not able to capture because we really concentrate on delivery of behavioral health services in the mental health sector, where the vast majority of the patients that have mental health or behavioral health. Now, when I say behavioral health, I really am including those with mental health conditions and substance use disorder conditions. So behavioral health would include both mental health and substance use disorder individuals. So 83% of the 31% spent on patients with behavioral health comorbidities is spent on medical service use. So that's an important thing to remember. So what are the practical manifestations of this separation of behavioral health and medical payments? Well, in the delivery setting, there are certain issues that come up. For instance, there are different provider networks and provider locations, which creates a challenge for, say, medical providers who want to have a behavioral health provider assist in the treatment of mental health or substance use issues, in identifying who those providers might be, because they're not in the same networks. And oh, by the way, they work in a completely separate location than where the rest of medical care is delivered. And so that creates a barrier for both providers and patients. There are also different inpatient admitting procedures. So if somebody is admitted to a mental health floor or a unit within a hospital, patients are not transferred from the psychiatric unit or the behavioral health unit to the medicine service or the surgery service or the obstetric service. They are discharged and readmitted. And the same is true going the other way. So if somebody is admitted to a med-surg unit, they are transferred to the psychiatry or the behavioral health unit. They're discharged and readmitted. And this really has to do with the coding and billing procedures, which are completely different for mental health and medical care. And that's one of the challenges that behavioral health providers have in delivering services in the medical sector, or for medical providers to deliver it in the mental health sector, is that they have to code and bill to completely different payers, despite the fact that they're practicing in a service location in which behavioral health or medical services are needed. A second area in which a practical manifestation of the separation of behavioral health payment occurs is in incentives and priority. So if you have separate payment systems, then each of the payment systems have discipline-specific payment maximization incentives and priorities. So in the mental health sector, you're maximizing payment by making sure that you get maximum payment for the kind of patients that you see in your setting. And even though mental health services are and behavioral health services are needed in the medical sector, in fact, it's difficult to get paid for that in the medical sector and to bill for that and to code correctly for that. And for the coders and billers in the medical sector to code and bill for mental health services. And so mental health practitioners tend not to work in those areas. The other area in which the incentive occurs is that you want to use in-network providers or practitioners for the care of your patients. And so the behavioral health people will try to use their own providers, even though they, in the medical sector, the patients may not be covered by the same behavioral health network of providers. And likewise, in the medical sector, it could be that, say, a medical group has a contract with United Health Group, but, oh, by the way, the behavioral health providers in the same hospital system are not covered by United Behavioral Health benefits. And so there's a disconnect there. There's also targeted discipline-specific outcomes so that behavioral health providers are really concentrating on making sure that the depression and or anxiety is getting better, rather than that the total health problems, say the anxiety and depression, is occurring in a patient that also has diabetes. So you're really wanting the diabetes to improve along with the depression and anxiety, but that's not the targeted discipline-specific outcomes that are concentrated on in the treatment processes. In addition, there's perceived need to target seriously mentally ill in the separate behavioral health sector, and that is certainly an appropriate thing to be interested in and to address. The problem is that an equal number of seriously mentally ill patients are seen in the medical sector for whom there is virtually no access to behavioral health services, and for whom transfer or referral for treatment in the behavioral health sector essentially never occurs because the patients are reluctant to enter the behavioral health sector. And then finally, there's limited cross-disciplinary service because of financial losses in each of the sectors. The final area in which there are issues have to do with financial vulnerability in the behavioral health sector. So there is a competing contracting for behavioral health and medical benefits, so that behavioral health benefits are primarily provided in the public health sector, where you have lower reimbursement and a challenge in getting adequate coverage. There's annually diminished behavioral health sector funding as a percent of the total budget, and this is definitely true since behavioral health reimbursement was formalized in the 80s as managed behavioral health was introduced. So the percentage of funds that go to behavioral health service delivery has dropped from in the 6 to 7% range to now the 2% to 3.4% range, as was documented in some of the initial slides. And this leads to a need for grant or foundation supplementation funding for behavioral health services. Furthermore, behavioral health providers are challenged whenever fiscal crises occur. This certainly happened during the housing bubble burst in 2008, but now that we have annual state budget shortfalls and the sequestration, the behavioral health budget is hit to a much greater extent than the medical budget. And so mental health services now are really impacting medical services for which there are no really capabilities in the medical setting to deliver medical services, because psychiatric hospitals, state psychiatric hospitals are closing, and community mental health centers are closing because of shortfalls in funding for the behavioral health budget. So what does this mean, and how does this impact outcomes and care living in a segregated reimbursement world? That is a behavioral health reimbursement world and a medical reimbursement world. So the first thing you notice is that the vast majority of patients that have mental health or substance abuse conditions get no treatment. There are now several national and international studies documenting that 60 to 70% of patients that have behavioral health problems get no treatment at all. That's zero treatment, none at all. Of the 41% that get treatment, it's only about 25% of those that see mental health practitioners. A significant number get treated by their GPs, and we'll see in the next slide that there's a challenge to that. So there's only about 25 to 30% that see either psychiatrists or psychologists or social workers or counselors. Certainly there are a number that see human services and or alternative healthcare, but they don't get exposed to outcome changing care that is generally delivered in the by mental health and substance use providers. So if you look at the quality of treatment, and this was a study done by Phil Wang and Ron Kessler several years ago and published, if patients are exposed to treatment in the medical sector by their primary care physicians, approximately 1 in 9 will receive what would be termed minimally effective or outcome changing care, whereas if they're treated in the mental health sector, it's about half will be exposed to effective or minimally effective care. Now that seems like it's not much, 50%. On the other hand, if you look at patients treated in the medical sector for hypertension, diabetes, congestive heart failure and the like, they have similar kinds of evidence-based administration of care for those chronic medical conditions. So it's about 50% of patients in the medical sector treated by medical practitioners will get effective evidence-based care. So we do about as well as general practitioners providing care in the medical sector. It's not saying that that's good, but certainly it's much better than the 1 in 9 treated by primary care docs in the medical sector that have really tremendous difficulties in getting outcome-changing care in that setting. So how does this impact care and cost of care? So this comes from, and part of the advantages that I have doing consulting to hospitals and clinics and to health plans is that I have access to large database, and this is a consolidated database from multiple health plans. And what you see here is if you take all insured in this particular population of patients, about $3,000 spent per year for the entire population. Of that population, about 15% will have a comorbid mental health condition. Now, if you subset that into patients that have one of the chronic medical conditions that are commonly occurring, like arthritis or asthma or cancer or diabetes, and you can see the prevalences of those patients in this population set, you can see that the total cost of care annually goes up by about double to triple. What most people don't do is they don't look then at those that have mental health comorbidity in those that have a chronic medical condition. And that turns out to be in the third column there, about somewhere between 30 and 45% of the population will have a mental health comorbidity if they have a chronic medical condition. And if then you look at the total annual cost of care for that subset of the population, it doubles or triples again. So that patients with arthritis that have a mental health comorbidity, instead of $5,000 annually, they'll be spending $10,000 annually. For patients with diabetes, instead of $5,000 annually, they will be spending $12,000 annually on total cost of care. And so to target this population and provide adequate treatment for them would seem to be a logical thing to do to improve total health outcomes and total cost of care. Now, interestingly, the majority of total cost of care for these patients is in the medical and pharmacy costs. So medical costs in this bar graph demonstrate, if you go to the far right, those that have depression, anxiety, and substance use disorder. If you look at the total cost for their care, The vast majority of costs, that is, the medical and pharmacy costs, are in the yellow components of the bar and the black components of the bar. Black is for pharmacy costs. The red component of the bar is for mental health services. So there's very little spent on mental health services and a huge amount of money spent for medical services and pharmacy services. And if you go to the far left component or bar, that is for somebody that has no mental health problems. And you can see that the total cost of care for them for medical and pharmacy services is much lower than it is for those that have mental health and substance use comorbidity. And so the majority of costs, and I just wanted to point this out, and this comes from Steve Mellick and the actuarial firm Milliman, that looked at patients with diabetes and then subsetted those into those with depression and those without depression. And in this subset, you can see that the total cost of care is about double. If you go to the far right-hand column there, and the total cost is around $1,288 for those with depression and about $750 for those without depression. And the majority of costs are for inpatient medical costs, incidental costs in the medical setting, and for outpatient medical costs. It is not for their mental health costs that the majority of costs are then realized in this population. So that it makes sense to move to a process in which treatment would be possible. So how does that show up in inpatient settings? Well, the average length of stay for those that have behavioral health problems, that is the columns on the right-hand side of this table. If you look at the red numbers, the average length of stay is about 6 days for a population of about 40,000 admissions in a year. The average length of stay for those that have no behavioral health comorbidity is approximately 4.7 days, so a 1.3 day differential. And the long lengths of stay, the differential for those that have 6 days or longer average length of stay is 27 days for those with behavioral health, 27% with those that have behavioral health comorbidity versus 19% in those that don't. So there's a huge amount of difference that you can see if you just look at claims data in hospital systems. If you look at constant observation in hospital, those that have behavioral health comorbidity will spend somewhere around $1 million to $3 million annually. Now, there are some community hospitals that we've worked with in which they say, well, we don't spend any, but they build in the sitters into their annual nursing budget and use ICUs for patients that are having behavioral health comorbidities in their med-surg units. And finally, readmission rates for those that have behavioral health comorbidity are about 30 to 70% higher if behavioral health comorbidity is found. Now, these are 30-day readmission rates, and of course, that is a significant interest in hospital systems because in the future, they're not going to be paid for readmissions to the hospital for patients that have common readmission problems. So where should we be going for with the Accountable Care Organization and health reform? So this is just a schematic looking at how the purchasers, fund distributors, and providers are going to be collaborating in building these accountable care organizations. And their charge is to meet the triple aim, and that is to treat total patients, improving care, improving outcomes, and decreasing cost. And yet we still live in, today, as we move into the accountable care world, a system in which medical service delivery is separate and paid for separately. So you have down below there the behavioral health payment process. So you have a separation of the patients and the payment for patients, just like we do today as we move into this accountable care world. and how is that going to impact in the future? Now, one of the things I would refer you to is the Center for Integrated Health Services. They have a website which gives you a state-by-state summary of reimbursement challenges that you have in today's world. If you want the coding and billing strategies that you can use in today's world, I would refer you to this, and the website is listed here. But essentially, if we keep the same payment system, you're going to find that large common populations will have no or inadequate behavioral health insurance, so that they will not have access to behavioral health services. And certainly the med-surg hospital systems are experiencing that in spades, where behavioral health patients are now showing up in the medical emergency rooms without access to behavioral health services, because, oh, by the way, they're all provided in the behavioral health sector, to which they really don't have access. There, of course, is variable same-day billing, which creates problems for behavioral health providers in getting reimbursed for patients that are also seen in primary care or specialty medical settings. Delivery approaches to maximize reimbursement and protect turf are used both on the medical side and the behavioral health side. There are, of course, inadequate professionals to care for populations. Almost no behavioral health providers practice in the medical setting, although there's an attempt to introduce integrated practices in outpatient settings. It is a huge challenge for medical service delivery organizations to pay for mental health practitioners in the medical settings, because reimbursement practices do not meet salary needs. And of course, there's discipline-based thinking about electronic health records, preventive measures, recovery. Even though the patients fall into care by both medical and mental health practitioners, we have a tendency to think medical or think behavioral, when in fact we really should be thinking total care of patients. So there's no common budget to develop integrated programs in the current service environment, and we really need to be thinking about moving in that direction. So the expected independent payment future outcomes is that we will continue to have service locations that remain isolated for behavioral health providers, salaries that remain non-sustainable, professional numbers that don't meet population needs, expertise that will be incapable of altering outcomes in complex patients, because complex patients typically have both medical and mental health comorbidities that interact. Referral access remains complicated and or impossible, and then clinical documentation, which is inaccessible, and care delivery, which will be discipline specific. Interestingly, more than 50% of patients with serious and persistently mentally ill are seen in the medical sector. They are not seen in the behavioral health sector, and many people in the behavioral health sector do not realize this, and essentially are leaving those seriously mentally ill patients to fend for themselves as far as trying to get reimbursement for and care for their health problems. So what would be a desired approach to moving to this accountable care, this new health reform era? Well, it would be to have the negotiations among purchasers, fund distributors, and providers that would include both medical and behavioral in one setting, so that the patients would be treated in a unified fashion. And this is just a schematic that describes that. Now, there's a concern by behavioral health providers that the behavioral health sector will no longer be there. In fact, that is not true. There will continue to be patients needing specialized behavioral health services, and there are mechanisms all throughout medicine to address specific needs for subsets of populations. There's pediatric clinics, there's diabetic clinics, there's pathology groups, there's imaging groups or radiology groups and obstetrics. Behavioral health would continue to be a subsector within the health services, but it really needs to be interactive and a participant within the total health care sector rather than isolated as it currently is. And so there is a behavioral health provider reluctance to change to becoming a part of the total healthcare infrastructure because there are existing infrastructures and power bases within the behavioral health domain. There are existing deals between behavioral health vendors and managed behavioral health organization and government agencies that people don't want to change. There's concern for a targeted and needy behavioral health constituency, which is real and needs to be protected. And there are worries about becoming worse off than the current system, even though year by year, behavioral health has been ratcheted down to a much greater degree than on the medical side. So there's concern about the fusion of decision making if behavioral health would become a part of the medical sector, and certainly behavioral health providers would have to be active participants in the development and delivery of integrated care capabilities moving forward, so they couldn't just rest and relax and say our patients are going to be taken care of. So how are we moving into the next sector of this health reform movement? Well, the current way that we are really thinking about doing, at least the way that this is rolling out, is that we have not really made any overtures to include behavioral health payment into the medical sector. So we have this standalone behavioral health sector, and what we're saying, okay, we'll do workarounds so the behavioral health people can interact with medical providers, and that's that red double arrowed line between the behavioral health providers and the medical providers, presuming that that would then meet the needs of the patients on the medical side who are not getting services. And there is no reason to believe that that is going to improve over what we currently have, given what we know about the competing budgets and who wants to pay. So a suggested behavioral health strategy, and this is where we get into alternative payment approaches, would be for behavioral health providers to roll into the payment processes for health. So they would just, behavioral health services would just be a part of health, and that they would be then a part of the health teams and build up and deliver integrated services to patients seen throughout the health sector. Now, this does not mean that there wouldn't be a specialty behavioral health a subsection within the health sector. That certainly would continue to be present, but it would be a little bit like dialysis units are a subsector of the medical practices and rehab centers are a subset of the medical practices, but they are reimbursed within the same payment system. Behavioral health providers should be reimbursed within this system, and this would be a much more logical way so that the total patient would be taken care of, and the triple aim could really be attempted to be achieved. So we come back to the Venn diagram that we saw earlier. Why should we do this? Why should we be concerned about this 80% of patients in the medical health sector? They really represent an opportunity for us, because if you put behavioral health services so that they would be accessible to patients that are currently not being treated essentially in the medical sector, there are a number of studies, and I'm not going to go over in detail this slide. You can request the slide set from Emma and AHRQ so that you can go through this. This is really to tell you that there are a number of studies demonstrating that integrating behavioral health services into a variety of medical locations, delirium prevention programs, unexplained somatic complaints, depression in diabetics and cardiac patients, panic disorder, case management, all of these lead to both improved health outcomes, that is both medical and mental health outcomes, but also cost reduction. And so we really have an opportunity here to contribute to this triple aim, which is being rolled out in the form of patient-centered medical homes and accountable care organizations, and we really need to be a part of that. And it turns out that this is really large dollars. So Steve Mellick, in doing his review of claims in commercial population, Medicare population, and Medicaid population, has been able to document that the amount of extra cost for patients that have mental health, untreated mental health, or poorly treated mental health and substance use comorbidity is approximately $293 billion a year. And if you only improve the care in somewhere between 8 and 15% of that, that's $26.3 to $48.3 billion a year savings to the total system. Now, just to put that into perspective, we spend about $45 billion in behavioral health services right now in the standalone behavioral health service sector. So if we would introduce behavioral health services and impact on this extra cost, which really turns up to be in the medical sector, we can really substantially contribute to improved health outcomes. So one of the things that the health reform leads to, supplementation of this opportunity, Parity Access behavioral health services are mandated in all of the ACA, accountable care organization, the exchanges and et cetera. There's a move to risk-based accountable care organizations so that the more that they can save in the populations they serve, the better off they're going to be. And if we can introduce behavioral health services that actually capture the savings as they improve outcomes for patients, that's a win-win for everybody. So behavioral health benefits as a part of all exchanges are expected, and a recognition that behavioral health is an important part of patient-centered medical homes, so becoming a part of those is all opportunity. But just relying on the parity law does not lead to automatic involvement of behavioral health services and access in the medical setting, as we've all experienced, because the independent payment process really creates a scenario in which there is an expectation, if you want behavioral health services, you have to be transferred to the behavioral health sector rather than getting it in the medical sector where the patients are, where they want to be treated, and where they have demonstrated evidence-based outcomes that lead to this improved care. So we really need to move to an integrated system in which behavioral health providers become providers of all medical networks, so there's no separate behavioral health network. That reimbursement practices are the same for medical and behavioral health services for patients, whether they have comorbidity or they don't. It doesn't mean that there isn't going to continue to be a behavioral health sector. There are certainly SMI patients that need special needs and special clinical delivery settings, so that will remain. But the majority of patients that have behavioral health problems, there will be the opportunity to actually integrate service delivery. So where is behavioral health positioned today in health reform? And I'm pretty active in the national picture in health reform, and I can tell you there is really no, with the exception of a small segment of behavioral health and medical providers, there is no vision for how medical and behavioral health integration will occur among the builders of programs moving forward. Behavioral health is largely discussed as an afterthought as you talk about patient-centered medical homes and accountable care organization development. And even as I would go so far as to say that in accountable care organizations, and I work with hospital systems that are building these, some of them are actually building into the bylaws that behavioral health providers are not allowed to be a part of the provider networks. And that really largely has to do with the fact that they practice out there in some other world and are paid by a completely different system. And so why would they want to have to address including behavioral health providers? Well, the answer to that, of course, is that behavioral health providers can build in this tremendous cost saving and health improving opportunity, but they don't know that at this point. So behavioral health is practically excluded from PCMHs and ACOs. They're really viewed as an external resource, and reverse integration, that is getting medical services for patients in the behavioral health sector, is as much of a challenge as it is moving behavioral health service delivery to the medical sector. So what are the alternative payment models? Well, as noted in the second slide in the slide set, there's the existing, where we have a lot of the problems that I've been describing. We currently have a transition attempt, which is trying to create workarounds so that a retained independent payment system can be reorganized in such a way that you can build workarounds so that behavioral health services in the medical setting and medical services in the behavioral health setting can occur. And this is where the Center for Integrated Health Services has come up with their really extensive state-by-state assessment of the billing and coding. And it is really very complicated and very challenging for providers, let alone patients, to get integrated service delivery. So a much better way, less complicated way would be for behavioral health benefits just to become a part of medical benefits in one payment system. And this is the payment alternative, or the model that is one that we should be moving toward. Now, we live in a system in which it will take about 3 to 4 years if we started today to achieve that. On the other hand, we should be moving toward that immediately, because we're not going to be able to capture the savings opportunity, the improved health opportunities that can occur with integrated care. Now, there are a series of additional presentations that AHRQ has talked about providing later in this year or sometime next year, that will go into much greater detail about how you would move from where we are today into the alternative. And that would be addressed from both the payer perspective as well as the professional or the provider perspective. So that's something that to look forward to moving forward. So if you take just a second, payment model 2, the workarounds, predictably that is going to fail, and that really has to do with the fact that medical and behavioral health budgets compete for who doesn't have to pay. So the cross-disciplinary personnel, it's very difficult for them to work in a cross-disciplinary section, because the medical sector doesn't want to have to pay for behavioral health services. That should come from that other budget. And behavioral health practitioners don't want to have to pay for the medical services, again, because that comes from the other budget. Integrated service settings are difficult to develop, because you have two payers, and the behavioral health payers want to build behavioral health service settings, and the medical service sector. And there are a lot of these comorbid patients that are really costing so much money that nobody can really address, because they're independent provider sectors that are trying to deal with them. It really maintains a competitive medical and behavioral health cultures, and we really have learned to live in separate worlds, and it perceives medical and behavioral health conditions as non-interacting, and it's very clear that the two are tremendously interacting and do affect both clinical outcomes and health outcomes. So the payment model that really we should be moving toward is one in which you integrate medical and behavioral health budgets. to maximize clinical, functional, and economic outcomes. It would mean full and common networks of medical and behavioral health providers so that mental health providers could work in the medical sector and get paid for the services they deliver without complications or barriers, just like medical providers could work in the mental health sector and get paid for the services they provide. There would be cross-disciplinary development of integrated services so that people would be looking at the whole patient and trying to maximize services. There would be shared upside and downside risk so that if improvement occurred, it would be both the medical and behavioral health providers that would benefit by that. And it would provide a more efficient and single administrative structure and acknowledge that medical and behavioral health conditions occur and interact. So this is the last slide. It says the future is yours to build, but there's a limited time horizon. Really, health reform does create an opportunity, a period of time in which opportunity exists for us to move in that direction. If we wait too long and we continue to persist in the separate payment system and the separate delivery system, we are going to likely be there for the next 20 to 30 years because we will not have we'll sort of get entrenched in what we build. So it's really time for us to be thinking about these alternative payment and delivery mechanisms so that we can maximize the care for not just the 20% that live in the mental health or behavioral health sector, but the 80% that live in the medical sector that are having challenges in getting integrated services or just behavioral health services provided. So I'll close with that. I know that we started a little bit late, about 5 to 10 minutes late. I don't know whether Emma will allow some questions, but I'm happy to address questions if there are.
Well, thank you very much, Dr. Kathol. We do have questions, so if you don't mind staying on a bit longer, we can go through those.
Okay.
Great. Okay, and just as a reminder, our webinar will be posted on our YouTube channel. In case you have to hop off now, you can go back and listen to the questions and answers. So the first question is the Center for Medicare and Medicaid as a key payer moving towards the integration approach you recommend? And if so, how?
It's very clear that they are interested in better addressing the care of patients that have comorbid illness because these tend to be the ones that cost the most or are the most complicated to treat. And there are a variety of strategies that they're using, including care management, including looking at ways to integrate services, and they're doing this through the innovation grants. And so, I think that there's a tremendous opportunity to try some new approaches to the way, number one, services are paid for, and number two, the way that services are delivered as a result of having greater capabilities. So one additional thing is that CMS has task orders that are also out there looking at, in the second innovations grant sector, there's a mandate that there be a payment reform component to the new integrations grants. And so medical and behavioral health payment reform fits right into these new innovation grants. And that's $900 million to be awarded during the next several months. So they're definitely interested in looking at new and alternative ways to approach this.
Great. How do you envision addressing more social determinants of care in this model?
It's very interesting. There's a perception that behavioral health patients are the only ones that have social determinants. And in fact, medical patients have huge social determinants and family determinants and personal determinants and religious determinants and cultural determinants and race determinants and et cetera that fit into care outcomes and total cost of care and things of that nature. So as we move into the new sector, not only are we wanting to look at both the medical and mental health issues, but we want to look at those in the context of the various social, personal, and cultural challenges that people have in getting and achieving health. And a lot of this comes in the form of, okay, we have care management programs that are really targeting complex patients, but the care management programs are either for medical problems, like congestive heart failure patients or renal failure patients, or they're for the mental health problems, the ACT teams, the assertive community treatment teams, and they tend not to do cross-disciplinary. Those really have to be included in the care management, just like social and personal factors that create barriers to improvement. So I think those are important to include. I don't want to minimize those. This talk was really not addressing that, but it is important.
Okay, our next question. It appears that there would be a great incentive for managed care plans to adopt this approach. Have any of the plans taken the lead in this? Why or why not?
So, the real challenge is that there has been a behavioral health payment infrastructure that has been built. The medical managed care organizations are now recognizing that their patients or their members, as they call them in the health plan arena, cost a huge amount of money, the ones that have comorbid mental health or behavioral health problems. And yet they have an infrastructure of payment that really creates a scenario in which the providers of care are really almost forced to work in segregated settings to deliver care. They would like, the medical managed care companies would like to alter that. However, number one, it's complicated, but not undoable. And number two, the behavioral health providers, that is the payers, are dead set against it because they make their money by carving it out and paying it for it separately. And so they have every incentive to keep the medical managed care companies from having an incentive to do it. But we clearly are moving in that direction. There are several states that are taking active steps to integrate the medical and mental health budgets. And that's a really great opportunity. And of course, some of the innovation grants are coming out with that process as well.
What will be the future of managed behavioral health organizations if behavioral health providers join medical networks and behavioral health services payment come out of the medical budgets?
Well, the behavioral health component of health plans are still important. I mean, you still have to have people that understand the behavioral health reimbursement process, but it has to be done in the context of total health rather than as an independent process. So what will happen as this transition occurs is that behavioral health managed care personnel will roll into the infrastructure of the medical. Now, there are carve-ins, and that is not integration of behavioral health. That's carving in. So essentially, in the carve-ins is that adjudication processes remain the same. In other words, behavioral health is still paid for in a segregated way. What really needs to happen is the benefits are written into the contract so that behavioral health illnesses become a part of any illness like diabetes or hypertension or chronic lung disease or what have you. So depression would just be a part of those illnesses and it would be paid the same way. Behavioral health personnel would roll into that medical infrastructure and participate in this integrated approach to reimbursement for services. But they would not be standalone nor just carved in.
Thank you. Would a capitated rate system work if it included both medical health and behavioral health services? Would SMI and non-SMI patients be included in the integrated care model you propose, or would this only be for non-SMI patients?
It would include everybody. It would include everybody. I mean, renal failure patients on dialysis and or transplant cost a huge amount of money, and that was a huge problem when that was rolled into the payment processes 10 or 15 years ago. There is going to be a transition process, and health for SMI patients is just as important as it is for anybody that has a chronic medical condition. And in fact, SMI patients, about 75% of them will have at least one chronic comorbid medical condition that needs to be addressed. So it would be for all patients. So all of the SMI patients would roll into this, just like those with non-serious mental illnesses.
Thank you. And we have time for two more questions. So, what, in your opinion, can insurance companies do to advance the integration of care and remove barriers that currently exist, like procedural coding differences?
Yeah, so the core is to create contracts, provider contracts, and patient contracts that in which behavioral health conditions are just a part of health, and so that there would be one budget for payment of health services, so that providers of behavioral health services can work in an integrated setting along with their medical service providers.
Great. And our last question for today, do we need to start getting this information to the public so they can add to the voice for change? And which decision makers need to hear this data?
Absolutely. The patients are the ones that get hit or hammered the hardest by having a separate system because they can't get care. Even seriously mentally ill patients will, I mean, you can go to any general medical emergency room, and the mentally ill patients have lengths of stay in the emergency room, oftentimes measured in days, if not long hours, 12 to 18 hours in an emergency room. And some patients stay there for 4 and 5, up to 12 to 14 days. And that's because they can't access mental health services due to the way that we pay for things. So getting patient groups involved in advocating for patients that fall into this comorbid condition situation is going to be extremely valuable, and getting advocacy groups for various kinds of illnesses involved in this. One of the problems with that, of course, is that many people have thought about mental health being separate for so long that they don't see this huge population of patients that's getting no care, and so they don't advocate for them. They really should be.
Thank you so much for your presentation today, Dr. Kathol, and thanks to you all for joining. Our next webinar will be on August 23rd at 1 p.m. Eastern Time with Dr. Michael Hogan, and he will be presenting on state-level policy enablers for integrated care. Have a nice afternoon.